afternoon, everyone. Thank you for logging in. I'm just going to give a couple of minutes for everyone to log in. If you can please remain unmuted, or muted rather, not unmuted. I would appreciate it just so that we can have a two-way consultation. I'm just going to give it a couple of minutes. My name is Toye Oboro, and I am a clinical pharmacist with a special interest in diabetes. So we're going to be covering gestational diabetes today, and we have the beautiful Dr. Martine, I'm not going to call her full second name because I know it all, Rukengwa Akintunde, who's going to be obviously answering a couple of questions with us. So I'm just going to give probably 2 more minutes and then I will kickstart the session. If people have got any questions, please feel free to ask them in the chat box and I will try and pick them up towards the end. We're going to try and run for as short and long a session as we can possibly do. Martine, thank you so much for coming in today.
It is a pleasure. Thank you for having me. Thank you for inviting me, Toye, and especially Diabetes Consult. Thank you.
Thank you. Thank you. Right. Do you want to introduce yourself?
Okay.
I'm going to leave the floor over to you to introduce who you are. I've said it on the flyer, but you can give us a summary of who you are while we wait for people to log in.
Of course. My name is Martine Rukengwa Akintunde. I am a friend, a sister, a wife, a mother, a doctor, a mentor, a director. But for the purposes of our meeting today, I want to focus on my medical side. So I am a registrar in obstetrics and gynecology.
Okay.
I'm very passionate about women's health and managed to work with, I've worked with several women, different professionals, different specialties. So it is a great joy and a privilege to be here today. Sorry?
I was going to say thank
carry
you for
on
coming
or stop?
Thank you.
I
thank
can
you.
speak, so you just tell me when to stop.
No, we're going to stop there. Thank you. Thank you for agreeing to come on. So today mainly is all about the aspect of diabetes that we're talking about, and also not really related, but related somehow to diabetes is female hormones. But we're also going to be talking about gestational diabetes. Dr. Rukengwa, are you able to please explain or tell us what gestational diabetes is?
Okay. Gestational diabetes is a type of diabetes that is diagnosed during pregnancy. And typically, you would be diagnosed as being diabetic during your pregnancy. And after the pregnancy, you're supposed not to be diabetic anymore. So that's the true gestational diabetes. That's what it is. It's a diabetic disease that is diagnosed or is developed during pregnancy. If you're still diabetic after the pregnancy, then it wasn't gestational diabetes. Then it's probably moved on to become a type 2 diabetes or maybe some form of type 1. But the pure gestational diabetes is a diabetes that is diagnosed during pregnancy. And the change is meant to be reversed after you've had your baby.
Okay. So you said that it's something that is picked up during pregnancy, the true gestational diabetes. Now, at what stage is it picked up? Is it immediately you're pregnant? How does it get picked up?
Now, to answer this question, I'm going to take two angles to it, if that's okay. So the first angle is this. Generally, if you've got risk factors for gestational diabetes, which I'll come on later, If you have risk factors for gestational diabetes, we offer, when I say we, I'm talking about the medical obstetric team, or the
Yeah.
obstetric team will offer to do a sugar test, commonly known as a glucose tolerance test, is abbreviated as GTT. So we would normally offer that to our ladies towards the end of the second trimester and the third trimester. So from 26 or from 28 weeks onwards. That's when we tend to offer that, because generally, if there has to be a change, generally it is easily picked up around that time. But if you've already had gestational diabetes in previous pregnancies, we will offer you a test probably before that, maybe around 16 weeks or so.
Okay, thank you for that. I think you touched it a little bit, but is there really a particular cause for gestational diabetes? And if so, what are they?
Diabetes as a whole, which I'm sure you would know as well, because you are specialist as well, for a pharmacy specialist in diabetes. It's a disease that is still evolving in terms of we are still discovering a lot of things, because it's quite a complex disease. I'm not saying that to worry or cause fear in our viewers, but I'm just saying that because it is an important disease, as it can involve other systems of the body. Now, you asked me what causes it. Is that what you asked me, Toyin?
Yeah, I said what causes gestational diabetes?
Okay. Now, generally speaking, when you become pregnant, there is a high demand on your body to help the baby inside of you grow. And when that process happens, of course, because of the hormone change, a lot of things change in our body to accommodate pregnancy. When that happens, it is not unusual that either the insulin that you have in your body can sometimes become less effective, which we call insulin resistance, or at times it may not be enough to meet up with the demands of your body to continue or to keep up with the growth that's going on inside of you. You probably ask and say, okay, Dr. Rukengwa, if that's the case, then everyone should have gestational diabetes. No. If that process is going on, everybody's body or genetics is very different. There are some people who may have existing factors that make them more likely to develop gestational diabetes when those changes are taking place. Some of these factors would include things like raised BMI. For example, one of the criteria we use in my trust where I work is to offer to offer the glucose tolerance test to women who have a BMI above 30, for example, because we know that a raised BMI can cause or can increase your chances or your risk of developing gestational diabetes. Things like also if you have a raised BMI, if you have conditions like polycystic ovarian syndrome, if you are, we've talked about the overweight, we've talked about the polycystic ovarian syndrome. If there is a family history of someone in your family who has had diabetes, sometimes also things like your ethnicity, from some of us from the Caribbean or African Caribbean background, or even some Asian backgrounds as well, can increase your risk of developing gestational diabetes. So together with the hormones and some of those factors, the risks of developing gestational diabetes is increased. And this is what, unfortunately, in some ladies, they may come back with the results that says they have developed the disease, and other women no. So it's not just weight, it's not just family history, but polycystic ovarian syndromes, and some people just predisposition due to family history.
Okay, thank you. So I think you've also covered we've got some questions coming in, which I will take at the end. You've covered this a little bit, and I don't know if you can expand a little bit more or if you've covered it completely. But you mentioned that there are risks to gestational diabetes. There's certain things that increases one's risk to gestational diabetes. Are you able to expand and tell us what these risk factors are? I remember you said that there is being overweight, having a family history, having a previous gestational. But for someone who's never had a baby before, what are the risks? Or people who may want to try to have babies, what are the risks?
I would say if you have a raised BMI, again, it's a potential risk. And I think earlier on I mentioned that the screening in my trust where I work is generally any BMI above 30 would offer you glucose tolerance test at between 26 to 28 weeks onwards. So if you have perhaps got a raised BMI, it's a good idea to try and work towards reducing the weight perhaps, and that could help you reduce that risk of gestational diabetes. The other thing that I want to just point out before I carry on is to say that there are risk factors that are under our control and there are risk factors that are not under our control. So if you've got raised BMI and you can work towards reducing the weight, I would really encourage you to do that. If you perhaps have got a diet very high in sugar and you don't have a raised BMI, but you have a diet very high in sugar, I would encourage you maybe to make some changes in that area, simply because if you are constantly stimulating your body to make insulin to control those sugars, you're more likely to develop some sort of resistance in your insulin. Therefore, it may not be as effective when you would need it during that process that takes place during pregnancy, and may increase your risk of gestational diabetes. So things like tackling diet, tackling weight, regular exercise, it could be, and I think the recommended time is probably about 150 minutes, just 2 hours and a half every week. It could be fast walking, something that is slightly making you out of breath, but you can still talk through it. That's another way of addressing maybe the exercise side of things. So factors like your ethnicity or family history of diabetes, these are factors that are beyond your control. There is nothing you can do about it, but you're hoping that by addressing the other factors, it will hopefully reduce any risk, at least significantly reduce the risks of gestational diabetes diagnosis later on in your pregnancy.
Okay, thank you. Thank you for expanding on that. Now, obviously, gestational diabetes has got to do with the woman who has a baby in her belly. How can gestational diabetes affect a pregnant woman?
Okay. We know already, and I'm sure Toy knows this because she's also a diabetes specialist, about what are the complications that can come from diabetes. We know that diabetes is a very complex disease, almost like a systemic disease, because it can affect various systems of the body. We're talking about liver, we're talking about kidneys, we're talking about eyes, we're talking about heart, we're talking about blood vessels, we're talking about so many systems in our body. Now, it's still the same similar process. In what way? If someone has been diagnosed with gestational diabetes, there are also at increase of other potential complications linked to diabetes. For example, we're talking about preeclampsia. Some of you may have heard about it. We're talking about preeclampsia, which is a disease that, again, affects pregnancy, but is somehow linked to the placenta, to the blood flow to the baby. And if you have diabetes, the blood flow in your blood vessels in general is compromised. And already, if your blood vessels are having to work hard, therefore, there is that small risk that you may develop high blood pressure in pregnancy, you may develop, which may lead to preeclampsia as well in pregnancy, which may lead to other complications of diabetes. Now, I just really need us to keep a very clear sort of distinction in our mind between, gestational diabetes and having type 1 and pregnancy, type 2 and pregnancy, because people with type 1 and pregnancy will have also some slightly more different complications compared to someone who's got gestational. But for this meeting today, a lot of the focus is about gestational diabetes. Thank you, Tony.
Okay. It's so broad, because obviously you have people who have type 1 diabetes and then become pregnant, people who have type 2 diabetes become pregnant, and people who have nothing get pregnant and then get gestational diabetes.
That's right.
So there is a lot, like it's a multi-factor and a map that we have to draw. Right. So you talked about the woman. Are there any other conditions that a woman with gestational diabetes can develop?
I would say if it's gestational diabetes, I've touched on it. It's mainly, I would say, if we're talking about conditions before we go into the pregnancy specific complications. So conditions, I would say there's a risk of raised blood pressure. And if your blood pressure is affected because of how diabetes can affect blood vessels and things like that, then if you've got high blood pressure, you increase your risk of developing kidney disease and things like that. So from that point of view, this is one of the high or the difficult things that may happen if somebody's got gestational or has got diabetes in general, but gestational diabetes in this context. Now, if we move on now to the pregnancy-related conditions or complications that can develop, we have talked about preeclampsia. Then we're also talking about, next thing we're going to talk about is another complication is your baby can grow so big, because if your sugar levels are not well controlled, your baby can grow so big. And of course, that will not be good for the baby development. That will not be good when baby is delivered, because baby's at risk of having very low blood sugars. And also, if there's a problem with baby's growth, you may be offered early delivery, early induction, and sometimes cesarean section. So gestational diabetes, as much as there's a lot that can be done to support you during your pregnancy, it is still an important condition to be aware about and to take seriously. The other important thing to note is that when you have been diagnosed with gestational diabetes, even though after you've had your baby, the sugars may have gone back to normal, or you may have stopped medication if you're on medication, you still need to bear in mind that there is still a risk that you may develop type 2 diabetes later on in life. So we recommend women that going forward after you've had your baby, we advise to maintain a healthy weight, to maintain a healthy diet, just again to prevent or to reduce the risk of developing type 2 diabetes later on in life.
I think you jumped 4 questions ahead.
Have
It's like you're
I?
sitting on my questions. Yeah.
I'm so sorry, sorry.
That's okay. That's okay.
It's
We're
a very
fine.
interesting topic, and I think that's
Yeah.
why I can't stop talking.
Yeah, I would just like to say that obviously if there are any women who've had babies or yet to have babies or are pregnant at the moment, this session is definitely, not to cause fear, but to bring education and to bring enlightenment, just so that we know how to deal with things to reduce the risk to yourself, to your baby, and to you, in the future. So it may sound like very daunting at the moment. That is not the reason why we're having this. It's so that we understand what's going on. We understand the risk if we've had babies who we've been told maybe 10 years ago that we had gestational diabetes and we've ignored it. It's just so we know what to do. So I just wanted to, put people's minds at rest. To clinicians, it's like, yes, we know this, but to somebody else, it'd be like, oh my God. But yeah, so thank you for that. Now, you talked about diet, initially. and I think you've already answered this, but obviously I'll just ask it again to be specific. Having had gestational diabetes or being told you're gestational diabetes, should one change their diet? And what do we encourage people to eat?
I think prevention is always better than cure. If you can do anything to prevent you from having to take the medicine or from having to take or seek medical help for a particular condition, then I think one should try. It doesn't mean it is easy. It doesn't mean it is practical. It doesn't mean it is something that will just happen overnight. But I think if one can make small steps at a time, I think it does count, because what you're looking for is that added effect. Every little step you're doing is moving you forward in the right direction. Mm-hmm. So I definitely think that if you have been diagnosed with gestational diabetes in previous pregnancies, even if it was 5 years ago, like Tony says, 10 years ago, I definitely recommend you have in mind that perhaps your body is very sensitive, perhaps your body is more likely to develop type 2 diabetes later on in life. So why not make the changes now? I'm not a dietitian specialist, but I can give you a general recommendation and advice in that regard, that, you know, if you want to change your diet, for example, what we normally recommend is that if you were going to the supermarket, I'm talking here for those who are perhaps living in abroad or in Europe or in the UK, if you go to the supermarket, you find labels that have got food that are color coded. Perhaps go for green code or amber code rather than going for the red coded ones, because they tend to have higher amount of sugars, higher amount of salt, higher amount of fat. The other thing I could say is that if it is all of us, whoever is from anywhere around the world, I think be conscious of oil, perhaps be conscious of how much sugar. If you used to have 3 spoons of sugar in your tea, for example, start by cutting by maybe 1, aiming to be completely sugar-free in your tea if you can. And then if it has to do with things like rice or pasta or vegetables, some of us who eat yam or potatoes. So try to look for food that have got, we call them low glycemic index, so much more simpler for the body to work on, to digest. And so things like if you go for brown rice or a brown pasta, again, it's a good thing. But some people, they've been recent recommendation that you can actually have some of the very thin basmati rice, which are quite low in glycemic index. I've just discovered that recently. So perhaps going for cooked meals rather than takeaways, because you don't know what they've put in it. You don't know how much they've measured in terms of sugar, salt. Perhaps going for yam is actually good in terms of low glycemic index, surprisingly. Maybe going for a boiled version instead of a fried one. So some practical steps. And also, if you are registered with a GP, they can give you guidance as well on some of the weight loss programs that they run to support you. And I'm sure also you can seek more advice as well through Diabetes Consult, because it brings together people from different backgrounds, a different specialty, in order to support you. Thank you.
Thank you. All right. One of the things we're going to be doing in a couple of weeks is we have a dietitian that we're going to bring up. So hopefully she will be able to break down things in terms of what exactly we eat. But that's in a couple of weeks to come. So thank you for covering that. Now, one of the questions I wanted to ask, because you talked about, we've covered the diet. You also talked about living a healthy lifestyle. Now, women, I know, when they get pregnant, they get worried, especially if you come from an African background. They don't want you to do anything. Don't do this. Don't lift this. Don't touch this. Now, would you encourage pregnant women to exercise? And what type, if you do, what type of exercise would you encourage them to do? And would exercise help them to control their gestational diabetes?
Absolutely, it would help them. Exercise, I would say, already as you go through pregnancy, as you progress through your pregnancy, it will become more difficult to do very, very heavy training. It's a natural progression of your pregnancy because you feel a bit more tired. However, you need to be active. Go for a walk every day, maybe half an hour. One thing we tell our patients that we see in clinic is that, after a meal, don't sit on the couch. Go for a walk half an hour. If you can't leave the house, you can actually go up and down the stairs, and you will be surprised how an hour after you've done that, when you recheck your blood sugar, it would have come significantly down. Because every time you exercise, your muscle is seeking more sugar for energy. So what it does is it takes the sugar from your blood, put it into the cells or the right places it needs to go, and that way reducing your sugar levels, which is what you need during your gestational diabetes. You need to keep your sugar within the recommended healthy sugar range. So yes, exercise, definitely I would recommend. Walking, fast walking, um, and fast walking as much as you can. Go with somebody, walk with you. Don't stay at home, because with pregnancy, it's not just gestational diabetes. There are other things like a clot. You could have a clot in your leg. So activity is definitely paramount when you're pregnant. Important, of course, within healthy range, within limits, but it needs to be something that you do regularly, because it has long-term benefits for you.
Well, thank you. Thank you. Now, obviously, we've talked about gestational diabetes. There's so many questions that are coming in, so I will take them once we finish the questions, if they haven't already answered the questions. Now, let's go on to medication. People do not like medication. Being a pharmacist, oh my God, it's a battle that we have to go through.
That's your field, isn't it?
That is my field. Now, having been diagnosed with gestational diabetes, would people need to take medication? Would they need to take tablets? Would they need to go onto insulin? What happens?
Now, once your body has gone through that change and you have developed gestational diabetes in your pregnancy, sometimes it's beyond your control. You can't always, even if you do the exercise or you control the diet, sometimes due to the nature of all the hormones and everything that's going on, sometimes you may need to take medication. Now, when you are diagnosed initially with gestational diabetes, the idea is to try and see if we can keep your sugar control, best or, healthiest for your pregnancy without having to use any medication. As much as it may sound so difficult to believe, but it is true. We really like you to try without medication if possible. So what would happen normally, you get seen by the dietitian as well, and then the dietitian would run through with you how to do your calorie count, how to choose your portion, because as much as you're eating the right food, you also need to eat the right portion. So they'll tell you your portion size, they will advise on quantity and timing of eating. When is the last time you could eat, not avoiding having late dinners, because then it just, as you go to bed, you're not going to exercise and it just brings your sugars right up, which is not good, because high blood sugars when you're pregnant is not good for the baby and is not good for you. So it's very important that it is maintained within healthy range. So initially, we don't say that you should definitely take any medication. We'll advise you on diet. Most ladies would end up on medication just because of the changes that are taking place. Diet may not be enough to suppress the rise in blood sugars. So moving on from diet, more likely you start on the oral medication. It could sometimes be, first of all, first line is metformin, but sometimes we can use another group of drugs as a tablet. But generally, we prefer metformin because it's kinder to the pregnancy, but also is something that we're more familiar with pregnant women and babies. Now, some women, despite the diet, it doesn't mean you stop the diet. No, you still maintain your healthy diet or your diet advised by a dietitian. You just add on the tablets. If your reading is not in range, even with the tablet, what happens is we increase the tablets gradually, steadily, and safely. And if, despite increasing it to the highest dose that we allow in pregnancy, your sugars are still not in range, we now introduce insulin. Because it's very, very important that we understand that just because you have introduced one solution, that you need to stop doing the other. And just because your sugars are in range, that you need to stop testing. Because by introducing insulin, as much as we're controlling your sugars, we're increasing your risk of having a hypoglycemic attack, which again is not good for you and is not good for the baby. So you still need to continue with your regular sugar checks as advised. You still need to maintain a healthy diet as recommended by the dietitian. You still need to continue taking the tablets and of course your insulin, because the doses may be adjusted depending on where how your sugar is behaving. And of course, if we're having to introduce insulin and all these things, then usually obstetrician will have to make a plan of perhaps a timing of delivery or that sort of thing, which again would depend on everybody. There's no set standard. It's different for everyone.
Okay, thank you. Thank you for covering that. I'm learning a lot, even though it's my specialty. um, so, are there any concerns? Obviously, you talked about that the baby gets the baby, the size of the baby increases with gestational diabetes. Are there any concerns for the children, like while they're in the mother's belly and after they've been born?
I would say while they're in the mother's belly, the main concerns I've talked about, baby can grow so much. So this could be a problem with baby's growth. And sometimes if the blood flow to the baby is affected, it can also affect the baby's growth. Other times, if baby is growing too much or the blood flow to the baby is impaired, then we may have to think about, okay, perhaps inducing you early. What is an induction? Induction is just when we trying to make you go into labor before your due date. So we may choose to induce you, or we may offer you a cesarean section, depending on what's going on. And of course, if if we induce you and the baby is very big, there are risks of things like your shoulder getting stuck, baby's shoulder getting stuck. And if the shoulders are stuck, there are high risk that baby may be injured in the process, even yourself, mom, as well, being injured in the process of trying to deliver the baby. So those are all important implications. There's even a very small risk that your baby may die in the womb, which is a very sad outcome, but it may happen. It's not common, thankfully, but it has happened. I have seen a case where it has happened, but the mom did not have gestational diabetes. The mom had type 2 diabetes. So again, this is not to create any fear, but this is simply to say that we need to, it's good to be informed, it's good to know, so that we can take the right actions to prevent any outcome that we do not want or we do not wish for. The other thing to note, if baby is very big, usually after the mother has had the baby, the midwife have to constantly be checking baby's blood sugar because of the risk of hypoglycemia for the baby. And if the baby is already very big, sometimes these babies may be at risk of being overweight. And if the baby is very overweight, then it's going to be difficult as they're growing up in terms of lowering the weight and all those things. So it's very, very important to do what you can, or work with your team, your obstetric team or your medical team.
Right, that's fine. Thank you so much. This is so enlightening. My question is, how does, which I've picked up, how is it that when a woman has got gestational diabetes and her sugars are very raised, she then gives birth to a baby who has low sugar? Is there an explanation for it? Is it because her sugars are raised that it then deprives the baby of sugar? How does it relate?
It has to do with insulin.
Okay.
Because the way mommy's insulin is working is not the same with the baby. So yes, they're getting big and big and big and big because they've got all these sugars around, but they can't, what's the word? The sugars are not actually doing what they're supposed to do inside of them. So this is why, even though they're big, because of the sugar environment they've been in, their levels of blood sugar is actually very low.
Interesting.
And this is why they get hypoglycemia.
Okay. Thank you. Thank you for covering that. Now, we've talked about how to reduce the risk of gestational diabetes. We've talked about when the baby is born. So we've talked obviously that the midwives would, not the midwives, the team that look after the babies after they're born would come in and obviously make sure the baby is looked after. What then happens to the mother? Are there any things that they need to do for themselves? Like, should they, bother? Because I know in clinic, I see people who you call in and you say you've had gestational diabetes, and they go, yeah, but I've had the baby and everything's over. Are there particular things that parents who've had children or have had gestational diabetes should do after they've had the baby?
This is a very, very, very good question. Very good question. And I think a lot of our patients forget to do this. And some of the type 2 diabetes get missed as well, like that, because the patients have forgotten. We recommend that you repeat a blood test that looks at your blood sugars. We call it HbA1c. 6 to 12 weeks after you've had the baby, even though your blood sugars have normalized. It is very, very important, because if they are still high, it could be early indication that you are now changing into a type 2 diabetes, or you're actually a true type 2 diabetes rather than just a gestational diabetes. Because remember, a lot of these conditions get picked up during pregnancy, because we do a lot of testing when somebody's pregnant. And this is why some of the things that perhaps could not be picked up in the community gets picked up after somebody has been pregnant or during pregnancy, because a lot of these things we do say, okay, go and have your blood checked by your GP. But a lot of us, or a lot of our patients, do not always do that. And then 10, 20 years later, when the disease has already progressed, then they begin to experience some of the consequences or the complications of the diabetes, because the disease has been progressing for all these years. Whereas if they had their blood test slightly earlier on, straight after they've had the baby, like 6 to 12 weeks after baby's been born, then if there is any abnormal blood results, then the doctors could have acted on it. Perhaps they would have had a referral to the dietitian. Perhaps they would have had some early medication or early review by a diabetic team, so that the sugars will be controlled and reducing any potential complications in the future.
Okay. Thank you for that. I'm just going to add to it. What we normally do, or what I do in my practice, is as soon as I get a clinic letter that someone's had gestational diabetes and has given birth, we will put you on we will code you as gestational diabetes, because you should have a test every year. So if you've had gestational diabetes with one child, two children, however, even if it's one child, and you've not had your doctors call you for what we call an annual review, then you should actually go to them and take the initiative, because the HbA1c is looking at how much sugar is within the red blood cells. So it gets changed because the red blood cells turn around every 3 months per se. So every 3 months it changes, every 3 months it changes. So we need to pick it up, annually at least. And it can tell us if you are in what we call a pre-diabetic range, which means
Right.
that you are getting to the stage where, yes, you had the gestational diabetes, which has increased your risk, but now you are getting to the stage where we need to monitor you, we need to send you to an educational program, we need to refer you to how you can change your diet, because you are heading in the direction of gestational diabetes. So it's just my thought to anyone who's on here who knows anybody who's had gestational diabetes or is pregnant after you've had the baby, make sure that your doctors are calling you for an annual review. And normally we link it to the person living with diabetes, their birthday. So, just so that you remember, as you're having a birthday, you're adding and you're celebrating, book an appointment, have a blood test done. Some doctor surgeries will say, no, you don't have to, but I'm saying,
You have
please
to.
book an appointment.
You do. You do.
Because it then reduces the complications and the risks that will come much later. I just thought to add that. Now, thank you. I've got just one more question around gestational diabetes, and then I would move to just touch on the hormonal bit. Now, once a lady has had her baby and she's had gestational diabetes, can she breastfeed her baby?
Absolutely. Please do. Breastfeed that baby. Please do.
Okay, because some people worry about having too much sugar and that they're giving their child sugar.
Remember what we said. You can't pass gestational diabetes onto your baby. No, you can't. So please breastfeed the baby. And remember what we said earlier. If you had gestational diabetes, your baby will be born with very low blood sugars. And we encourage you to start feeding them as soon as you can, as soon as possible, because they need the blood sugars. They need the sugars to go into their cell. Remember, you didn't give them your insulin, so they've got all this sugar around, but not in the right places. So they need to be fed. Definitely, they need to be fed.
Thank you for clarifying. Right, we're going to go on to female hormones now, because I get a lot of questions and sometimes I can't answer it because I am not a gynecologist or an obstetrician. Women obviously have a lot of hormones going on in their body. Now, as one gets older, we tend to pile the weight on, some more than others. Is there a hormonal reason why, like people say, oh, I get to 40 or I'm getting to the end of 30s and I just can't shift that weight? Is there a hormonal reason why this weight piles on?
I would say it's more of a slowing in metabolism rather than anything else, to be honest. Our hormones, yes, play a part, but they work together in that process. I'm talking here about before you go through the menopausal change, okay? Because anyone who has not been through the menopause yet, I'm talking about women who are still having regular periods, monthly or, I don't know, regular or irregular, but you're still having your periods. So you've got this lovely hormone called estrogen. It's not as nice as we think when we're having the periods, but it is nice because it gives us extra protection of certain things. It protects our heart, it protects our bones, it protects our muscles, it protects our skin. It has all these lovely advantages that come with it. However, when you go through the change, then definitely you don't make as much estrogen anymore. So it is switch off. That's why your period will stop. And then at that stage, it becomes more difficult to lose weight, okay? Because the good cholesterol that your hormones was helping you to make is not as much as it was before. So you're beginning to pile up the wrong cholesterol, which increase your risk of blood pressure, which increase your risk of other things, putting on weight, especially around the hips, around the abdomen or the tummy, around the sides. So the skin becomes all very loose, not as toned as before. Now, before you go through the change, I would say, yes, the hormones are there fluctuating, but it's a combination of your metabolism. Metabolism is the speed at which you're using up your energy. That's what it is. So if it is quite high, that means every energy you have in you, you are using it quickly. So that's why you see the way kids run around. As soon as they eat, they use everything up, they're hungry again. So people, as you grow older, your metabolism slows down. So you're not breaking or using up your energy as much as you were perhaps before. And this is why it's probably better to become more exercise conscious as we grow older, because exercise is one of the things that it does. It increases the rate at which you're using up your energy. It breaks things down a lot quicker so that you can have the energy to replace that. So I would say before you get to the change, so before the periods when your period would, your menstruation will stop, it's a combination of your hormones and the slowing up of energy, because your body knows that, okay, as you're getting older, you realize that even your appetite is changing. All of these are factors. If you go and see people who are in their maybe late 50s, they probably don't feel as hungry as they used to when they were in their 30s or their 20s, simply because the body is slowing down. It wants to keep up a lot of the energy because it knows that things are changing. However, when you are a lot younger, you're using up the energy a lot quicker because you're very active. You need that energy, so you are using it a lot faster. So ladies or gents, as we grow older, metabolism slows down. So we now need to do a lot of the work to stimulate the metabolism. Could be in diet or exercise.
Thank you for clarifying that. I was going to ask you, so with the hormones changing, the estrogen levels dropping and things like that, everything going on the inside, how do we then tackle, obviously you talked about diet and trying to exercise, but then you hear, especially certain cultures, where people feel that as they get older, obviously the bones start to ache a lot more. How do they tackle the weight gain? You know, are there any other means of tackling the weight gain or handling the reduction in the estrogen levels as one gets older? Should they do anything? Should they take any medications?
I would say, if you have been through the change, I'm talking for people who have gone through the menopause, which is through the change when your period has stopped, things will change, definitely. You may notice that maybe you've got a bit more back pain. Maybe we've talked about the weight. We've talked about some women develop slightly a higher blood pressure than they had before. Of course, depending on the level of exercise before you get to that change as well. So that's an important thing to mention. So I would say, if you have gone through the change and you're having quite bad symptoms with the low estrogen, there are things that can be done to support you. You can see your doctor, your GP, or we can, what's the word? Your GP that can give you. You can have medication. We call them HRT, some of them, but that's only if you've got quite bad symptoms. Because as much as they are good at relieving symptoms, so they're trying to help you with the symptoms that you're getting because of low estrogen, but they also have their own side effects. They also have their own problems. Like, there've been recent studies that have linked the use of some HRT with breast cancer and things like that. So, but there's plenty of advice around that. One could use it for a period of time and then stop, but that is purely if you have gone through the change. But if you're still having your periods and you're struggling in terms of weight, or you're struggling with other things linked to your hormones, then there are other types of help available.
Okay, thank you. Now, my last question, and then I'll go through the questions that have come through, is obviously we've talked about the hormonal changes and the slowing down in the metabolism. the fact that, you know, we have these hormones that are making our bodies as ladies, I'm talking to the ladies in particular now, do all these things, cause people to put on weight because of the slowdown of metabolism. Does that now predispose people to diabetes?
I would say it does affect that factor. It does increase, there is a slight increase, because if you, I know you're familiar with this, and maybe people in the health sector, about the metabolic syndrome. One of the things that is important in the metabolic syndrome is your waist circumference, the amount of fat around your stomach. So if you're putting on weight, and usually the weight is gained around the stomach, where we don't want, that's where the weight usually is coming. So yes, if you are putting on weight, especially in those areas, there is a small increased risk of developing maybe type 2 diabetes later on in life. But the other side to that is that even if you lose 10% of your weight, you still get benefits in reducing your risk of developing type 2 diabetes. So even if you don't manage to clear the whole area, because maybe it's very hard with exercise, it takes time to clear that area. But if you're doing the right steps towards your weight loss, you're doing the right steps towards your diet, remember what we talked about earlier, the cumulative effect. These added effects will produce a beneficial result for you long term. There is definitely a good prospect in terms of type 2 diabetes if one loses their weight.
Well, thank you so much. That's the end of my questions. So I'm going to run through, I think we have about 2 or 3 questions here. If anyone's got any questions, if you can send them to the chat and I would read them out. And hopefully Dr. Rukengwa can break them down for us. Now, the first one says that I've had gestational diabetes and I'm currently 32 weeks pregnant. I'm told at my growth scans that the baby is small, in the 10th percentile. What are the effects, and does that mean that I will be induced or have a C-section?
Okay, thank you for the question. How many weeks did you say?
32 weeks.
32 weeks. Thank you for the question. I would say that is going to be dependent on the doctor is actually looking after you, because you've given me information, but it's not a full picture, if you see what I mean. So I would say what would determine your mode of delivery is a whole picture, because the longer baby stays inside of you, the better. And I'm sure your obstetric team is aware of that. But of course, if it's becoming an unsafe environment for the baby, then usually obstetrician will decide what's the best way for you in terms of what's the best way to deliver you, the safest way for you and for the baby. I don't know if you've had babies before. I don't know if this is your first pregnancy. What I would say is that the decision to have a cesarean section or an induction, there are many factors taken into consideration. When you say that the baby is small, there's not enough blood flow to the baby, it doesn't say much. I don't know what it was like 4 weeks ago. I don't know what it was like, what it will be like 2 weeks ago. So it's in your case, if it can't be either induction or cesarean section, the team looking after you will decide as they go along. They will decide when is the best time to deliver you. They may offer you an induction if they feel it is safe, but if they feel that baby is not going to cope with labor, they may just offer you maybe a cesarean section. But these are things that they would definitely discuss with you. And I would say next time you see them, just ask them to tell you what are the pros and the cons, so that you can plan, yourself as well, to be more prepared in your mind. Because if they haven't mentioned any delivery for you at the moment, that tells me that maybe they are not yet thinking about it. They're still at that stage where they just want to monitor you, monitor the baby, and see how far you progress and when it is safe to offer you a mode of delivery, either induction or cesarean section. So there is a lot more in the story that I don't know, that you've given me a picture, but I need it needs a bit more clear picture to know what will be the final decision, because it's as you go. Every week is a lot for a baby to be inside of you. But of course, if it is not safe, I'm sure your team will advise you on the best way for your delivery.
Thank you for that. Now, the next question says, do sweeteners affect the body in the same way as sugars?
Now, sweeteners they don't affect the same way as proper sugar. However, they are not the best either, because they do have other side effects. And I think if one is really struggling with sugar, it's okay to use sweetener, but the optimal advice or the best advice would be to just stay away from simple sugaring things. If you want to take anything sugar, take something that is rich in complex sugar, which doesn't normally taste sweet. It just tastes like, if you've got Weetabix that has no sugar, so complex sugar have that kind of taste. So anything that is simple sugar, normally it is not recommended, because we know it will just put your blood sugar so high and stimulate your insulin, which may not be working as you want anyway, because of the gestational, and that's why you've got the gestational diabetes. So sweeteners, I would say, one could have, but I don't think it is without its own side effects. It's definitely different from normal sugar, but it has its own side effect too.
Okay. So if this person was not a pregnant lady and just wanted to use sweeteners, are you also saying that you're recommending to try and go without, or to use the complex sugar, or is that answer in terms of if someone's pregnant?
I was answering in terms of somebody's pregnant. On a normal everyday diet, I'm speaking from my own personal, my own personal opinion. I think even sweeteners, I will advise against, because there are different types of sweeteners. Some sweeteners do have some sugars in it, and other sweeteners have quite adverse long-term effects. So I would say if one wants to abstain from sugar, I would say even abstain from sweetener. But of course, if you're really craving for it and you don't want to have sugar, then there's no harm in taking a sweetener. But just remember, don't take it as a regular thing. I'm not eating sugar so I can have as much sweetener as I want. No, there are sweeteners that have some bit of sugar, and I've got some chemicals that are not good long term.
Okay, thank you for clarifying that. Now, someone asked this, I guess might be my question, but I'll throw it to you. Is there an alternative for metformin for gestational diabetes because of the size of the tablet? Are there any alternatives that you would recommend to use from an obstetric point of view in terms of metformin?
Yes, there is. Let me get the name right. Just bear with me. I always get it mixed.
Gliclazide.
Not gliclazide, is
glibenclamide.
Yes.
That's why I said it may be my option. It may be this
I
is my
wanted
section.
to be sure that I've said it right. Just
glibenclamide is a form of what we call sulfonylureas.
Yes.
And they act in simple terms. When I'm talking to non-medical people, I explain it as it's a little bit like insulin, but not insulin, but in a tablet form. Because what it does is it goes on the door of your pancreas and knocks on the pancreas to cause the pancreas to release insulin, to release insulin that is then required for the excess sugar in the body to get to where they need to go to. Now, there are risks of going onto things like glibenclamide or glycoside because they can cause what we call hypoglycemia, which is similar to what you get in insulin, because they can crush your sugar levels quite low.
That's right.
That you need to monitor your blood. So if you ask me, I would say metformin, we technically do not encourage to cut the medication because it then breaks down. I'm trying not to be pharmaceutical, but then it breaks down the pharmacokinetics or the properties of the medication. So if you can possibly put it within food, not crush it, but put it within food to swallow it. Or the worst case scenario, obviously, if swallowing, there's a problem with swallowing difficulties, then we can say in those situations, we get you to cut the tablet, but it's not encouraged to cut the tablet, cut the tablet and take the tablet. So that is my answer. But from an obstetric point of view, obviously, they're recommending that we use glimepiride as an option if metformin is the first line. It's one of the medications that we would we would definitely recommend, and we can deal with the swallowing much later. The other question was, we've talked about that, and I can see someone has put on here, is it normal to fall into menopause at 40? And what are the causes of this early menopause? And also, is it also normal to experience pregnancy symptoms at menopause?
I would say it is. You can experience pregnancy symptoms. But pregnancy symptoms, I bet they probably mean breast tenderness, nausea, mood swings, and things like that. I want to assume that's what they mean. So in terms of menopause at 40, yes, it does happen. We do call it early menopause. It happens sometimes, it does happen because your ovaries have just stopped working as they should. And as a result, you're not producing as much estrogen. And of course, with time, you go through that change and your period will stop and so on and so forth. So it does happen. There are women who go through the menopause early, so 40. And there are other causes. It could be genetic causes as well. So it's quite a long list of what it could be, but some of the things is due to genetic causes, or also if you've been on certain types of medications as well, they can affect your ovaries, which of course, if they are affected and have been switched off, you could go into early menopause. It could sometimes be some types of surgeries, perhaps where they've had to remove your ovaries, or some of your ovarian tissues were affected. Again, it could cause those sort of things. Yeah.
Thank you. I'm going to take the last question on here. Someone said, while going through my day, there are times when I get very lightheaded and I get a dizzy feeling. And it usually goes soon after taking something sugary. Is that related to diabetes?
I think the best way to know is to make an appointment or book an appointment to see your GP, and maybe have a blood test, an HbA1c, just to make sure it's not the case. Some people just use up energy quickly. Some people, perhaps you can eat, but your food is not full of energy. So if you just had salads and nothing else, of course, you probably run out of energy quicker than someone who has had maybe salad with a slice of bread, or some pita bread, or a bit of potato salad or something. So I would say, if it's something that you've noticed as a recurrent pattern, it's perhaps a good idea to get an appointment with your GP and have your blood checked, just to make sure you do not, you've not started going through some sort of change, especially if you've got other risk factors that could predispose you to developing type 2 diabetes later on in life.
Thank you. I think that's all the questions. We have obviously covered so much. This is everyone's saying, well done, very insightful session. So thank you so
Thank
much.
you.
It's a very
Thank
interesting
you.
topic, but I still do not want to be an obstetric or gynecologist.
I have a question.
Sorry?
I have a question for you, too.
Oh, okay. Yeah. So what's the question? I'm not used to people asking me. I'm used to asking the question.
I just wanted to say that I really, really like this platform that you have started and that you are building. It is very impactful. It's very empowering. It's offering an opportunity for information to be shared, and I really want to commend you for that. And my question is to say, like, what are you looking to see in this? I think it is amazing. People are going to benefit a lot from it. But I want to hear from you, the founder, the person with the vision.
Thank you. I'm just going to summarize it. I think for me, I've had an impact family-wise, where I've lost a very dear woman to my heart, and I'm trying not to get teary, being my mother, from mismanagement and misinformation, mainly mismanagement and carelessness of people, healthcare professionals, which has cost her life. I've had an auntie who's had a recent renal transplant, again from a lack of education. I've had someone who's now having severe blindness from diabetes, all family related. I've had heart attacks in my family and most of them are living not in the developed world, but in the developing nations. I've had aunties who've had amputations because of lack of education. I put it down to, if people are empowered with knowledge from the word go, or somewhere in the path of their journey whilst living with diabetes, it can help somebody's life get better. We are not God, and we do not give life, but God gives life. So I feel that by helping someone to live a better quality of life,
Wow.
because it's not a case of actually having a heart attack and living till you're 90 or having a stroke, but it's actually empowering people to live, to obviously live a very, very long, as long as God gives you life, but leave it with a good quality of life. And whereas in developing nations, as well as in the United Kingdom, because I manage diabetes patients within my practice, is that there is a very lack of education and there's a lot of information, but it can be so overwhelming. So I think it's mainly a platform to simplify and come down from being a clinician and come down to a patient's level and try and say, okay, these are the things that you're struggling, and create a listening ear to people. And that was what birthed Diabetes Consults, which will be officially launching in a couple of weeks. But the aim of this was just to provide information to as many as would listen, and especially to the African and the BAME community, not being judgmental, but we don't accept conditions, and we don't have the right information. And I think someone put on there that when we have things like Desmond or Derek, they don't, which are the courses that are offered to people who are diagnosed with diabetes in the United Kingdom. A lot of the information is not aimed in there, does not help people from the BAME community per such, because obviously, how do you tell me not to eat jollof rice or fried rice or yam or plantain, which is what I've grown up with, but I have diabetes? The essence is to say, okay, you can eat your yam, you can eat your plantain, you can eat your okra soup or whatever you eat, whatever nationality you come from. But at the same time, you can live with diabetes and enjoy your meals without worrying about things like aubergines. I like aubergines, but to people who I say to aubergines to my Bain community and they look at me like you must be having a laugh. So obviously just saying that to them and making sure that they have a platform that they can access a range of clinicians. So yes, Diabetes Consults was founded by me, but I'm still working on it. At the moment, I have about 9 clinicians that are coming on with me from different specialties, nurses, doctors, pharmacists, to podiatrists, dietitians that are going to come on a platform specific for people who are living with diabetes, at risk of diabetes, and help them. So there you go. That's my answer. I did not cry there thinking about my mom, but
Wow.
yeah. Yeah, thank you for asking me.
Really, thank
Yeah,
you. And
yeah.
I pray that the Lord will fulfill this purpose with you. You know.
Yeah. Thank you so much. And I want to say thank you to everyone who's taking time out of their busy schedule on a Sunday afternoon for the last 4 weeks. You'll be glad that this is the end of our 4-week session for the month of March. I've been asked to have so many requests for so many other topics around diabetes and high blood pressure. So I will take a break a little bit while we launch. And then I will come back, obviously, with information about other topics around diabetes. I will work with other healthcare professionals. So if you are interested in hearing about what we have to offer and the topics that we're going to cover around diabetes, please feel free to send your email address or email info@diabetesconsults.com. The email again is info@diabetesconsults.com, and we would obviously send you our newsletter. We would let you know when we're launching, and if you want to book in an appointment, then obviously by all means feel free to do so, and we'll be at your service, because my motto is your health is my passion, which is our
Passion,
passion.
yes.
Yeah. But I just wanted to say thank you to everybody for taking out your time. God bless you all. And while we take a break, obviously, log on to our session on Facebook, the private group, or on Instagram, or email us. Thank you, Dr. Rukengwa. I came
Thank
today.
you.
I have to remember I've known you such a long time, so the Rukengwa keeps staying in my brain. And thank you to all our viewers. And have a good
Thank
afternoon,
you.
everybody.
Thank you,
All right.
Tony. Thank you,
Bye.
Diabetes Consult. Thank you, everyone, for tuning
Thank
in.
you.
Really appreciate it.
All
Thank
right.
you.
Bye. Bye.
Bye.